Hello and welcome to the weaning and discontinuation from mechanical ventilation PowerPoint. So here we should be talking about stuff that you've already seen in other courses, and we're just going to sort of reiterate different ways to wean from mechanical ventilation, including using the ventilator in different modes, as well as using artificial airways and even including non-invasive ventilation. So let's get started. So learning objectives here, be able to list the weaning parameters that are acceptable for ventilator discontinuation, and do understand that some of those values are based upon normal pathophysiology. You really should consider baseline patient status before going into this in depth, because when one of our goals is to get that patient to their baseline. If we can get them to their baseline in a healthy state, then that can be considered their ability to become off the ventilator. So let's say someone has CO2 retention and they have really high CO2s at baseline. Are we going to wait till their CO2s are perfect in a wean before we extubate them? No. What if someone wears a lot of oxygen at baseline? Let's say they wear 6 liters nasal cannula at baseline. Are we going to wait till they're on just sort of room air numbers or 30% oxygen before we extubate that patient? No, right? So this is going to be something making sure they get back to their baseline. But do know acceptable parameters that includes your RSBI, that includes patient awareness and all that. So think about your baseline stuff. Compare the standard modes of weaning in relation to their success and discontinuation. Different methods may work better or worse for some patients and patient populations than others. So understand what the current evidence supports. So that way when you're out there, you'll see different ways that it can be done, but then you're also going to be aware of what the evidence says currently on those patients. Being able to define a closed loop mode of weaning really helps when we're looking at some of these newer modes that are out there that help the clinician understand, hey, this patient is ready, or hey, the ventilator is showing that the patient has very good parameters, and we could even tell the ventilator in some cases when the patient starts waking up to wean automatically. We've already talked about that with other modes like auto mode and things like that. So something to look at there, and recognizing the appropriate use of when these modes are appropriate. Sometimes these modes don't know that the patient is breathing shallow and rapid. All it knows is the patient's breathing on their own, and it feels like that's okay. But sometimes it just doesn't know they're breathing rapid and shallow. So that means we need to set our parameters good. We need to make sure that we understand that patient's physiology before we just let the ventilator do all those changes. Other things is just to make sure you identify the criteria for discontinuing on spontaneous mode, or determine whether the patient's ready to come off, or recognize the difficulties from the clinical description. So being able to recognize these difficulties in weaning is going to be pretty important, especially post-extubation difficulties, which you see here. Post-extubation difficulties is something that you can't really anticipate. You can prepare for, but you can't really know that every patient that you're going to extubate is going to be easy when they extubate or not, right? The joke is that we make plans, right? And then everything just goes crazy. So when we're looking at this, it's possible that someone could look very, very typical, very normal, and have really good parameters for weaning. And when we go to extubate, the airway just collapses on itself or something happens. So be aware of, you can't really predict every single patient that's going to have a weaning success versus a weaning failure, or extubation success versus extubation failure. So make sure that you are looking at this and looking for appropriate times when these patients will need success, and always being prepared if something does go wrong. What's our game plan? Stating the first recommendations for weaning, according to evidence-based, the American College of Chest Physicians here and the Society for Critical Care Medicine The AARC have all recommendations for weaning and mechanical ventilation. So they all came together and have different recommendations, and we'll go through a bunch of them here. And then making sure you know the treatment for a patient with irreversible respiratory disorder. So in other words, long-term ventilator patients. What are some long-term ways to wean these patients progressively off? Name the appropriate parameter for the primary index to drive to breathe. We'll talk about that. Even suggesting different ventilator settings uh, that will help these patients, and even explaining the procedure for how you manage a patient when they fail a spontaneous breathing trial. So that's something we don't really talk about too much, but here we'll try to address it. When we go to wean a patient and they fail, well, do we just say, oh, well, and then move on? Or how do we figure out what to do next? What is the next game plan for that patient that fails a wean? Why did they fail? Right? We need to figure out so we can move forward and not have people spend too much time just laboring on the ventilator. Defend the use of therapist-driven protocols. Protocols are key for your job happiness as well as for patient comfort and then expedient care. So having that protocol that allows you to be the driver as part of that care team when it comes to liberation from the ventilator really helps you be more in tune with your job. You'll get more satisfaction, you'll get more joy, and then not only that, when the patient's ready and everything's there, that means they can get quicker care, right? They can get more expedient care. We don't have to wait for a doctor to drive in, or we don't have to wait for a whole other process to go down before we can do this. Therapist-driven weaning is something that can be initiated safely and really does help give that patient the highest quality of care when done with evidence-based practice. So explaining the function of long-term care in those facilities can help these vent-dependent patients really have a higher quality of life, higher level of life expectancy, and really the families and the care team that surrounds the community that surrounds those patients really can benefit from good training in those scenarios. And then finally, look at the data used to establish the probable cause of wean failure. You're going to see in the chapter there's a bunch of different causes for weaning failure. So do pay attention to those. I won't try to hit all of those in here in this PowerPoint, but those are very good because if you're why did a patient fail a wean, those are some good differentials to help you understand, well, what could it be? Could it be a metabolic demand? Could it be their tube feeds are creating too much CO2, right? Could it be something in those ranges? So that's something to look at. All right, so let's start with weaning techniques. So patients require mechanical ventilation when their ability to support vent demands is outweighed by the disease process. So their respiratory drive is not keeping up with their respiratory drive is not keeping up with their disease process. It's inadequate. It can't maintain ventilation on its own because of the disease or because medications that we give patients. So they usually go into ventilatory fatigue or ventilatory failure. So ventilation, when we're looking at it, can be discontinued after the need for mechanical ventilation has been resolved. Let's say a patient has had a severe sepsis or a severe infection, and now that sepsis is resolving or been resolved. Now that means the original need for mechanical ventilation, the high metabolic rates, the ventilatory fatigue, all that stuff has been resolved. So that's when we can consider discontinuing the need for it. So it's always important to know why this person's on a ventilator. Typically, a very straightforward maneuver for most patients when we're looking at weaning is to simply disconnect the ventilator from the patient and the endotracheal tube is removed. That is one way, right, that you could look at. But about 80% of patients requiring temporary mechanical ventilation do not require gradual withdrawal process, and they can be disconnected in a few hours or days of initial support. So sometimes we may only need to keep some patients on for a couple of hours to a couple of days. Just like a post-op heart surgery patient, sometimes we only need to keep them on for a couple hours, and the sooner we get them off, the better. And then other patients, let's say it's also another post-op heart patient that's still bleeding and still has a very sick heart, we might need to keep them on. So the big idea here is, why is this patient on the ventilator in the first place? Why are they spending so long on the ventilator? What are our goals? What stage are we in? Are we in the stabilization? Are we in recovery? Are we in liberation? What phase of mechanical ventilation are we in? So we may not have to do days and days and days of weaning with most patients. Some patients, after a day or two, if it's, let's say it's a trauma patient, just a day or two on mechanical ventilation, they might be ready to liberate and be extubated. We may not have to do any more than 1 week trial, right? So it just depends what that person's on the vent for. So not every patient needs a long, drawn out weaning extubation, wean to extubate plan or protocol. Sometimes it is just, hey, when the patient's recovered, let them breathe on their own, and if everything looks good, then go ahead and pull the tube. So a lot of people can be withdrawn within a few hours to a few days of initial support. They may not need a lot of extra days and extra plans for weaning and liberation. Sometimes we're looking at these as post-operative patients, so especially those ones that are recovering from anesthesia, treatment of like an uncomplicated drug overdose or an asthma exacerbation, right? So those patients may only need mechanical ventilation until that initial process has gone through their system and we have everything under control. Patients that have undergone mechanical ventilation for less than a week, it's a pretty quick process to get them off. We're very rarely having any issues with diaphragmatic atrophy or anything like that. But for some patients, it can be very lengthy and complex. So we call term weaning is usually that gradual reduction of ventilatory support when their condition is generally improving. But there are a lot of providers that really prefer discontinuation, gradual withdrawal, or liberation. So no matter what they're calling it, the process overall is the same, even if we're using different modes or different methods. The whole idea is to progressively get this person off the ventilator if they have a more prolonged and complex case, or urgently if their case is not as complicated. All right, so techniques. So when we're looking at this, there are several factors that we should consider if we're going to take someone off successfully, right? If we're going to take them off, let's make sure it's success. So first, if they require vent support during weaning, so that's something that we have to look at. How much vent support do they need when they're weaning on their own? Second is how much oxygen and PEEP they're on. How much oxygenation are they requiring? And that's where you have to think about this patient's baseline. Sometimes a third thing that we have to think about is, do we need to maintain the artificial airway even after we have the vent support discontinued? So think about those patients that had severe strokes and may have lost their ability to swallow or protect their airway. Even though they might be breathing on their own, is there still that requirement for a tube to protect their lungs for breathing? So that might be a case where we might have to do a tracheostomy tube and have that prolonged weaning in that direction. Other times, sometimes patients require therapeutic interventions. So when we're intubating, sometimes that's a big part of getting patients through different therapeutic procedures like surgical procedures or even surfactant replacement therapy with babies. So those first three things that we talked about there can be treated separately. So they are a big part of the overall process of weaning. But when we're looking at this, ventilator support should be discontinued and the artificial airway removed as soon as possible to avoid all these risks that are associated with mechanical ventilation. And we've talked about a ton of them. One of the big ones is something called ventilator-induced lung injury. Ventilator-induced lung injury is where we have inappropriate settings, and that could cause trauma to the airways and remodeling of the airways as well. Ventilator-associated pneumonia or ventilator-acquired conditions, we leave them on, there's a higher chance for microaspiration and them developing a pneumonia that they may have not even came in with. So that's something to look at. What about trauma to their airway, right? From the endotracheal tube, tubes that stick it in their trachea. I mean, is it possible, even though it's made of materials that should help reduce the likelihood of trauma, is that something that could cause unnecessary damage to their airway, even if the cuff is at the right inflation level? But yeah, absolutely. What about sedation? What about that ICU delirium part that we talked about in the previous lecture for the rest of chapter 12? A lot of sedation could cause a lot of delirium issues, and that could be a big significant factor in patients' quality of life and length of stay. Those are big factors to think of. So recognizing that a premature withdrawal to a ventilator support can result in fatigue. So if we take someone's tube out too early, right? If the person hasn't recovered their muscle function fully yet and they fatigue, that could compromise their ability to breathe, right? Gas exchange. And then they can lose their ability to protect their airway, which could lead to a lot of bad things as well. So we need to make sure they're in the right place for discontinuation. You do want a rate of failure. I know it sounds weird, but you do want a rate of extubation failure as well to show that you're not just leaving people on for prolonged periods of time. I believe that number was somewhere around 12%, but I'll have to go look that up. But taking someone off too early could also lead to issues where they could have a higher mortality rate as well. So it's a fine balance between, is a patient good enough to wean to extubate, or should we still leave them on and let some more muscle recovery happen, right? Or more, whatever caused them to be on the ventilator reversed. So that's one thing you have to balance, right? Where are they at? Are they in that sweet spot where it's probably the right time, or is it too early or too late? This is where you, as part of the care team, can really be a big part of that discussion. So keep your ears and eyes open as well to what the other providers are saying. But weaning depends on the patient's level of recovery from the problems that put them on the vent in the first place. So where are they at in their physical condition? Where are they at in their psychological state? If this person's angry and thrashing around, I don't know that they're going to wean very well, right? They might pull the tube out themselves, right? So one thing that you have to look at too is their physiological capacity and their mental emotional status before you make an attempt to really remove them from the ventilator, especially if they're going to require things like sitters and other support. We might need to make sure those things are ready to go when we take them off the ventilator. So we're going to look at a lot of different techniques used during weaning, and we're going to look at a lot of evidence-based recommendations and seeing if they meet requirements for discontinuation. But as always, the big thing is the discussion in the care team about the clinical condition of this patient, what's their ability to wean, and then maybe in some patients we do a long-term care approach if they can't be weaned from the ventilation sooner than later. So there are three approaches that we like to use. SIMV is a very classic one, and some places still use this for their protocol, so pay attention there. Pressure support ventilation, very widely used, and even T-piece weaning. So we'll talk about these. But when we're reducing ventilator support, that means that we're letting the patient resume at least part of the work of breathing. So there's three approaches, right? We just talked about those. That we could go to intermittent mandatory ventilation or SIMV. We can go to pressure support or T-piece weaning. Really, it was the 1990s that all three of these were considered equally effective, right? But even now, it's more shown that weaning someone through SIMV, it was one of those things that complicated weaning. So you may not see it as much in there. But there's a lot of people in a lot of places that still use SIMV or IMV to wean patients from the ventilator. And that one's fairly straightforward. That one, you just continue to turn down that set mandatory rate until you get a rate of 10 or 8, depends on that facility. And with a rate of 8 and the patient looks great, then you extubate, right? So that was one of those things from times past. And you might still see it out there. And we used to use this a lot in our NICU too, where we would just have an SIMV and just progressively wean down the rate. And as long as the baby's blood gases looked good and their initial process looked good, then if they were on a low rate and everything looked great, then we would extubate. So things to look at there. So these methods have been also supplanted, or I shouldn't say supplanted, they've been also uh, uh, been in view of or compared with forms of closed loop ventilation, which these include volume targeted pressure support ventilation, so volume support ventilation, if you will. Auto mode, where the ventilator sees the patient's doing more of the breathing, so it takes them from being in a fully supported mode to where the patient's weaning on its own without you as the provider touching any buttons. It just, as long as you have auto mode selected, the ventilator will automatically do that. It's kind of interesting. Mandatory minute ventilation, and then even automatic tube compensation, artificial intelligence systems that are out there, the ASV, right? All those different types of modes that are out there can really be beneficial in weaning some patients as well. There were even some studies of proportional assist ventilation plus, PAV plus, that that Medtronics makes that has helped people get off the ventilator. So keep in mind there are other newer smart modes out there that could be used as well when we're looking at weaning. So let's talk about IMV or SIMV. This first started way back in the 1960s. I know I say way back, but in the 1960s, usually this was most used for infants that were in RDS, or back then they called it idiopathic respiratory distress syndrome, right? So IRDS, if you will. So a little history lesson for you there. But usually those patients back in the 60s and 70s, what they did is they added continuous flow, and then it allowed them to breathe spontaneous through a second bag or SIMV bag. It was kind of an interesting setup there, and there's a picture of it in your book, so it was an interesting setup. They had a blended gas source in this like little reservoir 3-liter bag, and we're talking adults here for a big adult circuit. And really, it was a one-way valve, so that allowed the patient to breathe through if they were trying to breathe on the ventilator and it wasn't delivering one of the mandatory breaths. It allowed them to breathe through that one-way valve into that bag. So it's kind of an interesting setup. But the gas bag would go through the humidifier, right? So it'd still be humidified gas. But during a positive pressure breath, the high pressure would close the one-way valve and then prevent the air from entering the bag and allow the mandatory ventilator breath too. So it was kind of an interesting system. So that was the way they set it up for patients that were on a ventilator that controlled it. Well, then they came out with SIMV, or synchronized intermittent mandatory ventilation, and it was a method to synchronize the efforts of the patient with the mandatory breaths. So the theory is that SIMV or IMV is that the muscle workload during spontaneous breathing, and you'll have the rest during mandatory breath. So it gives the patient that's almost partial support. It shares the work of breathing, if you will. So when we have CMV, it's the patient is doing very minimal work of breathing, as long as you have the right settings. During IMV, SIMV, the patient is sharing the work of breathing workload with the ventilator. And then during spontaneous mode, the patient's doing the majority of the workload of breathing. So where is your patient at and what system do they need? And that goes back to our initiation of ventilation lecture. So when we're looking at this, they're sharing that workload with the ventilator. So a lot of these modern ventilators have that SIMV that helps synchronize it with their breathing. So common practice was just to take the frequency down, right? Just progressively reduce the mandatory rate. So that way, 1 to 2 breaths per minute, right? And we're just going to look at the patient's improvement and then go off of that before we keep turning it down. You're not just turning it down to be cruel, but we keep turning it down, and then if we need to, we can add pressure support in those spontaneous breaths to help reduce any work of breathing that we're seeing in between. And we keep turning it down, and the idea there is to prevent excess fatigue, and then also to avoid atrophy as well as one of the other thought processes with using this mode that shares that work of breathing, and to avoid any type of atrophy on the ventilator. So usually when the IMV rate is 4 to 6 breaths a minute, then usually you're looking at a wean in the patient breathing on their own with just very, very minimal support. So when we're looking at this, the pressure support ranges that we typically use are around 5 to 10 centimeters of water pressure. And then that just depends on what tidal volume we're looking for. If they're breathing very small tidal volumes for their size, then we can turn down that pressure support from 10 to 8, right? And then target that appropriate tidal volume size. Or you could do your actual desired for tidal volume and pressure support. So PEEPA 3 to 5 is traditionally used, but most of the time we'll keep that PEEPA at least 5 on a lot of patients. We can go to ZEEP, but most of the times we do a PEEPA 5 to 6 to compensate for their functional residual capacity with being on an ET tube and lying down in recumbent position, which means there's more compression on the thorax as well. So something to think about. When we're looking at this, right, I just talked about this, reducing that mandatory rate to 4 to 6, and then 1 to 2 breaths per minute. We have that PEEP or pressure support can be added in some of these patients to help them. Like I said, a lot of times we may not go below PEEPA 5. It just depends on that current scenario with that patient. But the respiratory muscles really do a lot of work on both the mandatory and spontaneous breaths in SIMV or IMV. So you can see ventilator asynchrony because the patient's respiratory center does not anticipate the next breath is going to be a mandatory breath or a spontaneous breath. So when the mandatory rate is reduced to a point where it provides less than half of the required minute ventilation, the work of breathing for the patient actually may be as much as when support is withdrawn completely. So if the patient is doing over half of the work of breathing, this might be as well be considered a wean for some of these patients. So usually their spontaneous respiratory rate might increase if they're significantly if they're not ready to be extubated. So if you start to see that spontaneous rate or that triggering rate go over 35, that may be a sign they're not doing well with that low level of support. All right, so that was SIMV. Now we're going to look at pressure support ventilation. There's a lot of data, a lot of people very comfortable with this mode of weaning. So with pressure support, it controls the patient controls the rate, the timing, the depth of each breath. So pressure support is patient triggered, pressure limited, and flow cycled. Once again, and you'll see it on the screen here, it's point number 2. Patient triggered, pressure limited, and flow cycled. So that means the patient actually controls this. It's very, very helpful to let the patient be more in control here, so there's less asynchrony in some cases. There's very sophisticated monitoring and alarm systems on these modern ventilators that help this patient make sure they're safe, even though they're breathing spontaneously through there. So we have the apnea mode, we have the high rate, low minute ventilation, low tidal volumes, we have all those things to help this patient be appropriate. So let's say someone does come in and let's say they accidentally give this patient a paralytic. Well, that's where apnea mode comes in and triggers, and it gives the patient a set tidal volume, a set rate, something that supports them completely. So pressure support ventilation, as long as your alarms and your apnea modes and all that stuff is set up safely and correctly, can be a very safely effective way to wean someone. And then where we're looking at this is a non-volume supported approach. And it's been shown to be very safe, very effectively. And then what we're doing here is you as the provider can adjust the workload for each spontaneous breath to look at conditioning or endurance of the respiratory muscles without causing fatigue. So you can give that pressure support to titrate appropriately for the right size tidal volumes, for the right size minute ventilation as well. But really the most practical method of establishing the pressure support level is based on the patient's airway resistance. So you're like, Derek, how do I decide what pressure support to put someone into when we go into spontaneous mode? Well, you're going to look at the airway resistance. Typically, pressure support of 5 to 15 is appropriate for weaning criteria. So if a patient has very high air resistance, they'll need more pressure support, or very low air resistance, they may not need as much support. They might just need a little bit of 5 centimeters of water, right? So if that doesn't sound appropriate to the care team or to the situation, another approach you can establish the patient's is to reestablish the patient's respiratory rate, usually around between 15 to 25 breaths per minute, or tidal volume in adults 300 to 600 mLs. So when we're looking at that, we can look at the pressure support. And we can titrate it to look for their respiratory distress. We want to make sure that they're not in respiratory distress. So if you see the presence of respiratory distress, like they're tachycardic, they have high blood pressure, they start breathing fast, like a rate over 35, they're sweating, they do the seesaw paradoxical breathing, or maybe they have pulsus alternans, right? So if you start to see those things, do you have the right amount of pressure support? I would say no. Right? I would say no. If they're using a ton of accessory muscles, do you have the right amount of pressure support? I would say no. All right, so that's something that you'll have to look for when you use this mode, and that can help you titrate up or titrate down your level of pressure support. So 5 to 15 is typically what we're using. When we're doing this, it will gradually reduce the level of support as long as there's spontaneous respiratory rate and tidal volume and no respiratory distress are shown. So if we're in a pressure support of 15, then we can reduce it down, right? And then if we don't see any distress, or we see the same rate, same tidal volume, then we can take it down again. So the pressure support's usually reduced about 5 centimeters of water pressure. The big thing there is just making sure you're taking those small steps over time to avoid the patient from going into further fatigue. But usually that minimum pressure support is 5 is what's needed to overcome the work of breathing through the whole ventilator system. So the resistance, airway resistance of the ET tube, the trigger sensitivity, right? They have to pull just to trigger a demand, the flow demand capabilities, the type of humidifier you use could even play a factor. What if there's an air leak in the ventilator circuit around the cuff or a chest tube? That could all interfere with pressure support breath termination too. So things you have to look at here as well. So traditionally we do a minimum of 5 of pressure support. There is some studies out there, your book doesn't necessarily talk about those, where they do pressure support of 0 and a CPAP of 0, and that's how they would look at the RSBI. So something that you might hear or see out there too. All right, what about T-piece weaning? So T-piece weaning is one of the oldest available techniques, and I am a fan. I kind of like this, but I'm kind of older in the field as well. Originally involved when we would take the patient according to a predetermined schedule, we'd take them off, and the patient would, of course, breathe spontaneously, and we would just sort of take them off and do a T-piece adapter, right, with high flow rate. So we're going to hook up a heated venturi or heated aerosol to the airway and take them off for maybe 5 to 10 minutes and have them breathe spontaneously, and then we'll return them back to the ventilator for the remainder of the hour. So they used to do this once an hour, and then the time off the ventilator was gradually increased. So maybe it was 10 minutes this time. Well, maybe it was 30 minutes the next time, and 30 minutes off the next time, right? So we'd have the patient on the T-piece for 30 minutes, breathing through their own, and then we have them back on the ventilator for 30 minutes, right? So they kept doing this until the patient would breathe on their own to an hour, and then sometimes even longer than that. So that's not how I T-pieced weaned, of course, but that was the history of that T-piece weaning. But the setup for a T-piece, usually you're going to get a heated humidifier of some sort, a large reservoir, right? And you connect it to that blended gas source. So that's why I say that Venturi, or that heated aerosol that you would use just like you use for your trach patients. And then you're going to set your desired FiO2. And then you're going to get your T-piece adapter, and then there's pictures of this in your book, and then you're going to attach that T-piece to the patient's endotracheal tube. So, and then you're going to have a tubing that you attach to the other side of the T-piece that acts as a large volume reservoir. So that would help maintain humidity, and if the patient inhales gas flow through the tubing from the humidifier side that's inadequate, from the inspiratory side that's inadequate, that might help keep the gas humidified that they're breathing in as well, right? And even their FiO2, so it could help keep their saturations up. So I kind of was a big fan of this version of it, especially if we're able to get their peak flow or their total flow rate higher than what they could get through the ventilator circuit itself. And that was a limitation of the ventilators that I would use back in the day. So while they're disconnected from the ventilator, the big thing, you have to have a high level of staff attention, right? We have to make sure someone's watching this patient while they're not connected to the breathing machine anymore, right? So you can see that, is there any alarm systems when they're just breathing through heated aerosol tubing? No. The alarm system would be the monitoring, and you don't want to wait till the monitor says their heart is gone before, or their respiratory rate is gone before you do something. So usually a T-piece wean, you're going to be in the room or just outside the room monitoring the patient when they're doing this. You can T-piece wean through a ventilator. So you set to a spontaneous CPAP level, then you have no mandatory rate. But the advantage of them just breathing on a CPAP through the ventilator with no pressure support, right? That's supposed to stimulate the C-piece, the T-piece. The advantage of using it through a ventilator is you have the alarm. So if they stop breathing, it'll actually alarm and go into an apnea mode. And if they start breathing too shallow, if they start breathing too fast, if they start having any of those issues, the ventilator will alarm, and then you could take quicker action. So that's one good advantage of T-piece weaning through the ventilator. The disadvantage is their effort to breathe through the ventilator circuit might increase their workload to breathing, so they're going to work harder to breathe. So a lot of the newer ventilators, thank goodness, they usually provide a bias flow through the system and flow triggering that really helps reduce that workload on the patient's work of breathing. So it's very similar to a small amount of pressure support with the bias flow that goes through a lot of these event circuits. So using a T-piece trial using the ventilator instead of just doing the heated aerosol thing really is a good advantage nowadays, right? They have more bias flow through the circuit. And then we have that apnea mode, we have the backups, we have all that stuff to have as a support of that patient when or if they fail that wean. Patients are less likely to tolerate T-piece weaning when they have heart disease or severe muscle weakness, because remember, they're doing almost all, if not all, the work of breathing, and sometimes more work of breathing than patients who are using pressure support weaning. So these patients also might be more likely to be panicked if they have pre-existing chronic lung conditions because they're not getting the pressure support they're used to. So that's something to look at too. When they looked at studies, and this is where I start talking about more studies, yay! Studies comparing the SIV weaning, pressure support weaning, T-piece weaning have a lot of conflicting results. You're like, that's not the news I wanted to hear, is that, hey, all the three major ones out there are conflicting. Each mode of weaning really offers particular benefits to certain patients. So if one procedure does not work well for a patient, try another, right? Ventilator weaning is best accomplished when the expert, the staff members, are willing to be cooperative and find alternate ways to get these patients off. That's where I've been telling you in the past. We've had patients that have failed weans on traditional pressure support ventilation. And then we've tried SIMV and it worked. I've had other patients that failed traditional pressure support weaning, and we've tried T-piece. Those are my heart patients where they're on the vent because of hemodynamic, and we're trying to figure out if their heart's healthy enough to come off, right, with that reduced pressure support level, with no pressure support, sorry. That really helps us see if their hearts are healthy enough to take them off yet. So it's a good idea if one way doesn't work and it's not successful. Hey, what are the thoughts of trying another way? Because these reports are conflicting, but as long as the staff members are in agreement and they all know how to do wean in these modes, then that's where I think these things can show their different value to different patients that have failed multiple times. All right, so we've talked about the three major methods. What about closed loop control? So closed loop control vent modes, we're going to have a set variable that's compared to a controlled variable. So the ventilator will use a feedback to adjust the output of the system. So things like volume support to very complex ones such as ASV or adaptive support ventilation are very advanced closed loop techniques that have been used for weaning. Even automatic tube compensation, which helps give them as much to reduce the resistance of breathing. Volume targeted pressure support, or volume support if you will. It's the same thing as what I just said. So volume support ventilation, mandatory minute ventilation, adaptive support ventilation, artificial intelligence modes like ASV, right? Those modes can really be helpful also as another method to get these patients off. So we'll talk about these different methods: automatic tube compensation, volume targeted pressure support, or volume support if you just want to put volume support there. That's what that is. Auto mode, which is available on the servo. Mandatory minute ventilation, adaptive support ventilation. I think that's Hamilton's. Obviously, then artificial intelligence systems. So we'll talk about each one here real quick. Automatic tube compensation. The idea here is the work of breathing might increase when a patient that's breathing spontaneously breathes unaided through an endotracheal tube. So the amount of increase is directly related to the size of the artificial airway of the patient. So when the smaller diameter is used, or if we increase the length of the tube, that increases the resistance to flow. Yay, Pose's law. Do you guys not remember that? That's one of the favorite things. I love teaching about that. So anything like kinks in the tube can factor into that, biting the tube. Anything there will make for a high minute ventilation, and that will increase the spontaneous work of breathing for the patient. So how do we get rid of all the airway resistance of the tube? Well, we can use low levels of pressure support to help compensate for that increased work of breathing, but we don't know. We're just sort of titrating to effect when we're doing the pressure support mode. But we know that that's a fixed pressure, and pressure support ventilation really doesn't as accurately compensate for the variable flow through the ET tube, because inspiratory flow, the patient, can vary from breath to breath, right? Do you take the same volume of breath right now that you took 2 seconds ago, right? Your variable flow is just a normal thing. And so that pressure support doesn't account for that. So that fixed level of pressure can be too little support if you have a really high or fast inspiratory flow rate, or it could be too much and feel like you're being garden hose is pouring down your tube, right? So that flow rate could be too much or too little. So it could be excessive, too much tidal volume, too much flow rate, and be very uncomfortable for the patient. And that's a big thing to be concerned about, right? Especially if we're using lower sedation levels. So to overcome that problem, there are some ventilators, like Medtronics makes one of them. The Dreiger makes another one. They have I think General Electric also had one. They make a feature called automatic tube compensation. And so the whole design was to specifically, right, surgically, in a way, right, reduce the work of breathing with that increased endotracheal tube resistance. So the whole point is to be very precise in compensating for the work of breathing of the patient with the automatic tube compensation. So theoretically, it delivers the exact amount of pressure required to overcome the resistance that the ET tube is giving the patient for the flow. So it's providing variable pressure support with inspiratory flow compensation. So think about it as a variable pressure support mode that's very specific and calculated. And the whole idea is to target the pressure at the trachea level and adjust the pressure support to try to maintain that tracheal pressure at a constant level. So if the flow gets highly resistive, then it will adjust it appropriately. So what we do need to know is make sure that we're monitoring the inspiratory and expiratory flow rates. And that's what that whole vent mode is supposed to do. It's going to use that closed loop control, right, where it calculates tracheal pressures. So usually you have to plug in the size of the tube here, and then it's going to continuously calculate as pressure drops across the tube when the breath is delivered. So usually you have to select the automatic tube compensation function, and then you say what type of tube, whether it's an ET tube or trach, and then select the tube size. Is it a 7.5? Is it a 7.0? Right? So a lot of times that's very helpful, right? That's how it does its algorithm or its calculation. But some ventilators allow you to select both the inspiratory and expiratory automatic tube compensation also. So expiratory tube compensation, it's a hard thing to look at here because it can cause premature closure of really unstable airways, so patients that with COPD. So we don't know whether it eliminates dynamic hyperinflation or auto air trapping, right? But we'll need more studies to sort of look at that issue. But traditionally, we're looking at inspiratory. So what are some disadvantages against or arguments against automatic tube compensation? Well, really, it may support spontaneous breathing without overcompensation or undercompensation. So the idea that its advantage is to find that the patients have more comfort with it because it has variable pressure support. And so that's the idea there. And if they have discomfort with it, then that's something that we're going to have to pay attention to. When we're looking at this, is it needed to support someone that's breathing spontaneously, right? Until their minute ventilation exceeds 10 liters a minute, the effect of the tube really may not be significant for some patients. So it may be a no issue unless their minute ventilation is pretty high. So if they have a high minute ventilation, usually that's where we're going to see more issues with the resistance of the tube. So a high minute ventilation is not very often that we see that for intubation, for an intubated patient breathing spontaneously, right? So if they're breathing spontaneously and they need a minute ventilation over 10, then unless they're a really, really tall person, then that person probably needs to be in an assisted mode, right? So also, if you're using an appropriate size tube, the work of breathing may not be any greater through the tube than it is through the upper airway once the patient's extubated. So there are multiple studies where they found that automatic tube compensation was equivalent to a pressure support of, you guessed it, 5, right? Equivalent to a pressure support of 5 and a CPAP of 5. So if it's equivalent to using those basic weaning modes, right? 5/5, then why would we say that that's something that we need to consider when we can just use a pressure support mode, right? So in some cases, tube compensation can give the false impression that the patient's ready to be extubated when their person is dependent on the vent support, and the vent support supplied by automatic tube compensation, even though it's minimal. So depending on the vent model, tube compensation may not provide sufficient compensation for the work of breathing imposed through the ET tube. So it depends on the algorithm that machine uses. So automatic tube compensation really may reduce the workload of breathing and increase comfort depending on the ventilator and what type of artificial airway the patient's using, but we need more studies. Here's the big bullet point. We need more studies to determine whether tube compensation provides all the benefits that it was designed to do. So we just need the evidence there. But there are some concerns that it may under-provide support or may over-provide support as well. But we just need this right now is just one other method that can be used successfully to extubate patients who are difficult to wean. So if you're having trouble getting a patient to wean and you have a ventilator that has tube compensation, it is an option for you. All right, volume support ventilation. So this mode, usually I've seen it on the Servo I ventilator, but pretty much it's basically pressure support mode with volume target. So the volume targeted pressure support, you're going to put in a set tidal volume while using pressure support criteria. So it's patient triggered, pressure targeted, flow cycled, right? When we're using volume targeted pressure support, the advantage here is you're maintaining a target volume. So their minute ventilation is very stable. So the idea here is weaning patients from a ventilator. We can make sure that they're not hypoventilating, but we haven't used a lot of studies with volume support that I'm aware of at this time of recording. So I could be wrong, so pay attention. But there have been some drawbacks noted with using volume targeted pressure support ventilation, but it is a method out there that can be used successfully. Auto mode. I've used auto mode successfully in my past. This one is available on the Servo by McKay, that ventilator. Mine was a Servo I, but I'm sure it's on the newer versions of the Servo ventilators as well. It's very similar. It's called variable pressure support or pressure control, so VPS or VPC, and it's also available in the Venturi ventilator as well. So auto mode, or this VSVPC, right? Whatever you want to call it, is activated when the ventilator can switch from being a time-triggered mandatory breath to patient-triggered supported breath. So let's say you have someone that's post-operative and the patient's still recovering from anesthesia. What you do is you select a volume-controlled CMV mode, right, for that patient because the patient's not within enough to breathe. So you put them with auto mode as the operating mode, and all the breaths are mandatory, right? They're time-triggered, volume-limited, time-cycled, right? So if the patient begins to trigger breaths, the ventilator will switch from being in volume support, switches from being in volume control to being in volume support. So then it goes to patient triggered, pressure limited, flow cycled, and volume targeted. So it remains in that volume support mode as long as the patient is breathing spontaneously. So if the patient becomes apneic again for some reason, or doesn't detect any patient effort, the ventilator will switch back to its VC-CMV, right? It'll switch back to that full support. So auto mode can be set to switch from pressure controlled CMV to pressure support if they're more comfortable with that pressure support method of weaning, or pressure support method of weaning. So that's something that you could consider with the care team as well. And it's been shown to be pretty effective on patients. And it really requires fewer vent manipulators and techniques. And like I said, it's automatic. It does it. You could come into the room and see that they've been weaning for 20 minutes already. So there are clinical studies that need to evaluate more completely how auto mode is effective as a weaning technique. So it needs some more support, but I do think it is a very advantageous mode for certain patients. Where I seen it was actually a pediatric ICU patient that had a little bit too much alcohol to drink. Right, we're talking an older pediatric patient. We're not talking a little kid here. Yeah, he just needed to wake up, and when he woke up, I seen that he had already been weaning for quite some time, and so he was ready to extubate. It was pretty neat. I didn't have to be at his bedside the whole time waiting for him to wake up. The ventilator automatically put him into that wean as he started triggering. It worked out very well. All right, mandatory minute ventilation. This has been around for a while. Back in 1977. Wow. So this was on the Drager ventilator, and it's a closed loop method as well. The parameters that it looks at is, of course, the frequency and the tidal volume, that mandatory minute ventilation. So when we're looking at this, like what we see with IMV and pressure support weaning, we're going to have a constant level that is not guaranteed. So mandatory minute ventilation automatically increases the level of support as their spontaneous ventilation decreases. So it gives them a consistent minimum minute ventilation. So patients who regain the ability to breathe spontaneously can increase their breathing on their own, and the machine will automatically titrate or lower the support without you having to change any vent settings. So potential benefits are pretty strong when we're looking at this, but there's not a lot of clinical studies that use MMV as a weaning technique. So a lot of times this was used as a regular mode and not as a weaning mode. So keep that in mind. The target minute ventilation, when you're using this, you set a target minute ventilation set slightly below the patient's total minute ventilation. So this includes both their mandatory and spontaneous breath. So if a patient's on CMV, right, and they're not hypocapnic or alkalotic, then you could set it at 80% of the patient's previous minute ventilation level. So a little bit lower. So 75% or less might be perfect if a patient's slightly alkalotic, or for patients that are in SIMV, setting it at 90% of the IMV might be appropriate as well. So this is another method that could be used, but there's just not a lot of evidence behind it currently. Potential problems or hazards is that the rapid shallow respiratory pattern could really provide could give them the minute ventilation they want, but it would cause an increase in dead space ventilation. So you're usually going to see that decrease in compliance is also associated with pulmonary congestion, where they breathe faster, pulmonary edema, pleural effusions, pulmonary fibrosis, atelectasis, pneumonia. So it can be associated also with that rapid shallow breathing pattern. Can be an abdominal issue. We talked about that with dynamic compliance, or decrease in muscle strength, right? If they have a neuromuscular issue, Guillain-Barré myasthenia gravis, ALS, right? Spinal cord injury, right? So as a precaution, your high respiratory rate and your low tidal volumes alarms need to be set tight if this is the mode that you're going to use. Other problems, you could develop autopeep. If you have really high tidal volumes, right? So if you have an inappropriate set upper pressure limit, that could really impact it. You could see an increase in dead space ventilation. We talked about that. If you have inappropriate understanding on if you misapplicate it as well. So you need to be aware of that whole dead space to tidal volume range. If it sees that minute ventilation, it doesn't know that it's breathing fast unless you set that alarm tight, right? And that they're breathing shallow unless you set that alarm tight, right? So be aware that carbon dioxide production could increase if they have more dead space. the patient could work hard to breathe, and that could set their days on the ventilator back, right? We can do a lot longer stays on the ventilator if we don't give them the appropriate support. So their breathing pattern, the gas exchange can vary. So you need to watch them closely in this mode. So it's been available for 3 decades, but research is still very lacking on this mode. But nevertheless, is it a tool in your toolbox that you could use for people that are difficult to wean? Yeah, there it is. Ooh, adaptive support ventilation. I like this one. This is available on the Hamilton ventilators. Both ASV and the adaptive lung ventilation were designed to make automatic adjustments all the time, from initiation of ventilation until weaning. So it's pretty interesting. This is an artificially intelligent mode. It's a patient-centered closed-loop way of doing this, and it's based on looking at the patient's parameters. So it provides a pressure-limited breath that target volume and a rate. And the rate and the tidal volume are selected by the ventilator's algorithm. Once again, let me repeat that. The rate and the tidal volume are selected by the ventilator's algorithm to provide minimum work of breathing for the patient. So the ventilator, I believe it's the Otis-Mead equation, automatically selects the rate and tidal volume to make for a minimum work of breathing of the patient. So it looks at pressure, it looks at flow, it looks at inspiratory and expiratory time, it looks at compliance and resistance, time constants, and it does this to ensure a delivery of acceptable minute ventilation based on what you have set. So these settings that you're doing, it includes the patient's ideal body weight that you're putting in there and a high pressure limit. You're also going to put a PEEP, FiO2, rise time, flow cycle, the percent of predicted minute ventilation desired, and then that will change with altitude in certain situations and certain clinical processes. But the whole point is ASV is designed to minimize the work of breathing and auto PEEP. Right, it's designed to minimize work of breathing and auto PEEP. So it's worth looking at ASV as an effective ventilator management strategy for patients in variety of situations. So this one's very versatile. Post-thoracic surgery or thoracic surgery patients. It's also been studied as a strategy for weaning. ASV has also been shown to be safe and effective for traditional methods of weaning. And it has been suggested that it may find increased use in the future. So artificially intelligent mode here, this adaptive support, might be something you'll see more of down the road. So artificially intelligent systems, right, usually relies on a lot of technology. So the only commercial system, there's a smart care pressure support system that Dreiger offers, and this uses a range of volume, frequency, end-tidal CO2. So it's going to use end-tidal CO2 or exhaled CO2 to adjust the inspiratory pressure. So it's actually going to look at CO2 levels, right, which is something we haven't quite seen yet, to adjust their inspiratory pressure. And that will help maintain the patient's in a respiratory zone of comfort, that they call it, right? So the patient's readiness for extubation is based on the predefined lowest level of inspiratory pressure. So a lot of factors will go into that, including the type of airway, whether it's an ET tube or tracheostomy, what humidifier, right, if they're using an HME or heated humidifier, or even if they're using automatic tube compensation. So those are things that we'll look at and see as well. Once the lowest level of inspiratory pressure is put in, then you're going to observe the patient during their tidal volume. It's going to look at the tidal volume, frequency, and end-tidal CO2. They're all going to be monitored. And if the patient successfully passes that spontaneous breathing trial, that modified spontaneous breathing trial, it will display a message that actually suggests that the clinician should consider separating the patient from the ventilator. In other words, it will tell you the patient's ready to be weaned or possibly extubated. So it's actually prompting you, saying, hey, take a look at this patient. They might be ready, right? So it doesn't do it for you, right? But it does alert the clinician. It does alert you, right? So this approach may be a viable alternative because it uses and it reduces the duration of mechanical ventilation ICU days. So the big thing is additional clinical trials here, right? So that will help better define the use of these systems and to ensure the use of them as a highly studied method. So other than that, there's a lot of advantages to this artificial intelligent way of doing. All right, so we talked about a ton of different methods. We spent an hour doing that. So let's finish it up here with looking at the evidence behind these things. So the challenge of successfully getting someone from a ventilator has been very debatable. So a lot of solid evidence identify the readiness to wean, and there's a lot of people that really continue to look at the different ways of trying to make sure the patients are safe and ready. Are we doing too many criteria, too little criteria? What research do we need to continue to do? So there's a lot of debate that you're going to see out there. One of the things that we look at looks at a literature review. They did an American College of Chest Physicians, the Society for Critical Care Medicine, and the American Association for Respiratory Care tried to create an evidence-based guidelines for ventilator weaning, requiring more than 24 hours of mechanical ventilation. So these guidelines form the basis for much of the material in the remainder of the PowerPoint. So these are where these things are coming from that I'm about to speak about. So 3 key points have evolved as criteria for weaning. Hey, the problem that caused the patient to require the ventilator must be resolved. Number 2, the certain criteria should be assessed to help establish a patient's ready for discontinuing. In other words, we need to find a criteria for saying the patient needs to be discontinued. And the third one, a spontaneous breathing trial should be performed to firmly establish readiness for weaning. All right, recommendation number 1. Although you overlook it a lot of times, the primary pathological event that led to them being on the vent should be corrected. So you must determine if the disease process or the condition has been improved to the point where we can get them off or been reversed altogether. So if not, weaning attempts unlikely to be successful. Let's say that someone's in heart failure and their ejection fraction still, let's say it's 20%. Not good, right? How successful do you think they'll be at weaning, right? So we're unlikely to be successful if we don't have that either mostly reversed or reversed. So their recommendation is that all the causes for the reason being on the ventilator might be contributing to ventilator dependence. So we should look at what caused them and then make sure whatever caused them to require that ventilator is something that we make sure is reduced or treated before we consider weaning or extubating them. So whatever led them to being on the ventilator should have been improved or reversed, or their overall medical condition, and everything that caused them to have that work of breathing has been reduced. What if their psychological readiness is not there as well? So those are all things that we have to think about. We need to look at the patient's overall condition, and any ventilator parameter or physiologic parameter outside normal range could interfere with their ability to breathe spontaneously without vent support. So more than that, is it appropriate that if one is out of line that we not consider weaning? This one parameter is out of line that we consider not weaning? No, by no means. So we have to look at the whole situation and approach it as a care team. So when we're looking at this is trying to predict whether a patient's ready to be weaned or not, it can be a little difficult in some patients. Some patients might be healthy enough to wean, but not necessarily healthy enough to extubate. So you have to pay attention, you have to be part of that care team and do your full assessment here. So when a patient's medical condition is stable and the patient's breathing spontaneously, they're alert, they're cooperative, then you can look at the gas exchange values and see if they're really ready to wean. Often, weaning criteria can be met on most patients, like what I was saying earlier. About 75% of patients who meet weaning criteria usually will tolerate their initial spontaneous breathing trial, but establishing a wean for their vent discontinuation could be successful, but even among patients who never satisfy weaning criteria, right? About 30% of them can be weaned from the ventilator. So sometimes it may not look pretty, but it may still be a very stable process. So big thing is looking at measurable criteria for predicting success on mechanical ventilation weans. So there are a lot of physiological parameters that can be helpful in adults, but there's no single measure that has uniformly been shown to be successful in predicting a patient's ability to be weaned and have an uncomplicated extubation. It just doesn't exist right now, right? And if you come up with it, I would love to say that I knew you. Let me know, right? Don't deny that you ever knew me if you come up with such an equation or a way to do that. But an ideal weaning index would really look at several parameters altogether, and help look at different factors, including the patient's muscle strength and all those other things, their mental status, what their initial injury was, right? So there's going to be a number of factors, even beyond what I just mentioned. So the idea here is to use your whole assessment toolbox with coming together as a team to identify what weaning criteria this patient does meet, and then if it's safe and effective for the patient to do so currently. Traditionally, you monitor the patient for that 30 to 120 minute wean, depending on the patient's toleration, and then we can see how they're breathing during that, their mental response, and we can make our decisions on that. For a lot of years, we'll try to look at things like muscle function, like a vital capacity, and some vents have a spontaneous mode or respiratory parameters mode where you can make the patient do a vital capacity maneuver. We'll look at their minute ventilation, we'll look at their rate, we'll look at their spontaneous tidal volume, we'll look at their rapid shallow breathing index. The vital capacity hasn't been shown to be a good predictor for some patients when we're looking at this, because it's only looking at a muscle strength for one breath. And also it provides the patient cooperation, which is not always consistent, especially if they're a neurotrauma patient. What about the rate, the tidal volume, RSBI? You can do that with a bedside PFT device, a respirometer, or like I said, a lot of ventilators can do that as well. To see how that patient's doing, you just have to go into certain modes to see it. If the respiratory rate is easy to count, and it can be a fairly reliable guide to their ability to tolerate a workload. That's why we try to make sure that the respiratory rate's less than 35 in a wean. And if it is greater than 35, it usually indicates they're not ready to be weaned. They're still breathing too fast. They're still trying to compensate for some sort of disease process or something. So the pattern of breathing is also going to be valuable. All right. You should look at the patient's sedation as well. Maybe the sedation is altering their breathing patterns, or the injuries that might be altering their breathing patterns. Even the RSBI, which is the most frequently studied and one of the more reliable tests for looking at weaning status, with that one, you're just doing the frequency over the tidal volume in liters, right? So frequency over tidal volume in liters, so decimal point. So if they're on 350 mLs, so let's say it's a rate of 20, so it's 20 over 0.35, right? So you take this 1 minute after disconnecting a patient and look at their spontaneous breathing from the ventilator, and then you usually had a Wright's respirometer, you'd get a minute ventilation, count the respiratory rate, and then divide the minute ventilation by the respiratory rate to get their average tidal volume. Then you do that tidal volume in the RSBI. But anyway, some people will do this with CPAP and pressure support, but at RSBI less than 105, so normal range is 60 to 105, but values above 105 usually suggest the patient's not ready for weaning and probably would fail a weaning trial. One of the other things you have to look at is your formal assessment. Does the patient have reversal of underlying cause of their failure? Do they have adequate oxygenation, right? Is their PaO2 greater than or equal to 60 millimeters of mercury? Is their FiO2 less than or equal to 40%? So do keep in mind the patient's baseline with that whole FiO2 thing. What about their PaO2 to FiO2 ratio? Is it greater than or equal to 150? That's a good idea that their diffusion's getting better. Let's say it's 150 to 200. That's a good idea that their PF ratio is getting better. Are they requiring high amounts of PEEP, or are they on a PEEP less than or equal to 8, right? Is their pH over 7.25, right? So look at these parameters. Do they have hemodynamic stability? If a person has severe hypotension, and that's not a good sign that they're going to do well on a wean. So let's say they don't have signs of hypotension, they're not in the vasopressors, or even just like a low dose like dopamine or dobutamine that might be there for renal perfusion. Right, because it could be there more than just for vascular support. It might be there for renal support. Then we could consider that patient ready to wean as well. Is the patient capable of breathing in on their own? Do they trigger the ventilator? So we should look at that as well. So your assessment techniques will come in pretty handy here. Recommendation number 3, look at them during the spontaneous breathing trial. So when you're looking at discontinuation assessments, you should be doing them during spontaneous breathing rather than while they're on a lot of vent support. So when we do the spontaneous breathing trial, this is where we're looking for how they're looking, right? So you're not just looking at them during full support, you're looking at them during the wean. And then you're looking at that to determine their tolerance of the trial. So what's their respiratory pattern when you switched them over? How well did their gas exchange? Did their end-tidal CO2 go up? Did their saturation go down? Did their blood pressure change? Did they look more comfortable? Did they look uncomfortable? So patients that tolerate a spontaneous breathing trial of usually 30 minutes to up to 120 minutes in some situations usually are considered for vent discontinuation. But if they fail, the causes of failure and the reasons that require them to be support should be determined and corrected. So if they fail wean, why did they fail? And then what can we do about it, right? Why did they fail? And what can we do about it? So one reversible cause of the failure, once we reverse the cause of that failure, and they still meet criteria, then we should do another one in 24 hours. So if you get a future question, it says, how often should we attempt weaning as long as the patient's stable to do so? The answer is 24 hours, right? Every 24 hours, as long as the patient's able to do so. Recommendation number 4 here is removing the artificial airway. Yay, right? For patients, when the support from the ventilator has been successfully discontinued, obviously the big thing is, should we remove the artificial airway? Is there patency of the airway? Should we do trauma anesthesia on standby, especially if they had a traumatic intubation attempt or difficult airway, right? Or should we extubate over a bougie or a tube changer, or right? Should we make some other things available if we're going to do this? So one of the things that you need to look at when we're finally ready to remove the tube itself is things like hoarseness, sore throat, all those post-extubation difficulties. Coughs, those are all common. You want to chart those things. Subglottic edema can happen, increased work of breathing from secretions, right? Because now there's no positive pressure, so those secretions can come out of the woodworks, right? Airway obstruction can easily happen. They can have laryngospasm after you extubate. That's probably on you for not extubating during end inspiration, but hey, that's my thing. Don't tell people to cough and pull it out while they're coughing. You're just asking for stridor and edema and all that good stuff, but that's my viewpoint. Post-extubation edema can result in obstruction of the airway and cause stridor. So usually this is treated with some cool aerosol or even nebulized racemic epinephrine, that 2.25%, 0.5 mLs, 3 mLs total, right? You can use Heliox, a 70-30 mixture, or you can use through a non-rebreathing mask, or you can even use CPAP too, right, to help stent open that obstructed airway or that upper airway that's narrowed, right? So those things could help reduce work of breathing through that partially obstructed airway. Heliox is just for low density gas, right? You're just using low density gas. The big disadvantage of the Heliox is the evidence behind it is a little aged, but physics, it still makes sense that it would work, right? And then you're only giving 30% oxygen, so that may not be enough oxygen support for these patients. So you want to give them time for treatment, whether it's racemic epinephrine or steroids, to take effect and then prevent reintubation. But you may have to reintubate if they have a lot of respiratory distress after you extubate, if they have post-extubation edema or stridor, and they're refractory to the treatment, or they have laryngeal spasm right away. So you may have to respond and give them positive pressure, bag mask ventilation, if they're working really hard to breathe. And you might have to give them a neuromuscular blockade, sedation, and reintubate. So the big risk here is aspiration as well. So that's why we try to turn off tube feeds or anything like that before we extubate, not like right before, but like hours before, or, so that way their stomach isn't full of stuff. So if we have to bag them, we're not back pressuring it. But aspiration is usually associated with the inability to protect their airway. So that's something that we have to take note of too. If they have a neurological injury, like a spinal cord injury issue or anything like that, do they have the ability to protect their airway? That's part of your assessment technique that you should take into effect. When we're looking at this, does it preclude you from extubating? Not always, right? So this is part of the care team. Things that also increase aspiration after extubating, muscle relaxants, gastric tubes, so feeding tubes. Usually we try to discontinue, like I said, tube feeds for about a couple hours, so 4 to 6 hours before we extubate. Anything that is that causes the glottic sensations can really cause them to have that aspiration if they can't close their glottis mechanically. So let's say it's been impaired after extubation, right? A lot of secretions, let's say they have cystic fibrosis and a lot of secretions. If they have the inability to adequately cough as well, those are all factors that really could be complications of removing that airway. All right, what about non-invasive after we extubate? It can be beneficial for patients who require some degree of vent support. This will help ease the transition from invasive mechanical ventilation to spontaneous breathing, and usually has a lot of benefits. It's been shown when we use it for extubation, and people are like, what's the point if we're just going to put them on BiPAP? But it's been shown extubating to BiPAP or extubating to non-invasive improves survival, lowers mortality rate, reduces the risk of ventilator-associated pneumonia. It's been shown to lower the incidence of septic shock. It shortens the ICU and hospital stays. So there's a lot of potential benefits for using non-invasive after extubation, especially patients that just need a little transitional ventilator support. So you can do it temporarily for subglottic edema to give medications that reduce swelling like corticosteroids and giving those time to take effect. But you can also use it for preventing reintubation when respiratory failure occurs after you extubate. So the big thing here though is patient cooperation is essential. So non-invasive tolerance cannot be safely predicted before we extubate. We can't predict how they're going to do with it before unless they were on it beforehand, before they were intubated, right? So when you're looking at this, the deliberate intent to switch to non-invasive, if we're extubating, just to know that we're going to automatically switch to non-invasive, can carry a high risk for reintubation to begin with, just knowing that they may or may not tolerate it. Patients that fail spontaneous breathing trials, that's where we have to look at what happened, why did they fail, what is the cause, right? Before we consider this again, when the reversible causes of failure have been corrected, and they still meet criteria for discontinuing ventilation, then we should do another spontaneous breathing trial every 24 hours just to make sure. It's important to avoid pushing patients to the point of exhaustion during the wean. So you can't just let them go all day, right? Breathing on their own. They could go into that fatigue again, breathing through that tube just by themselves, right? And so that could actually delay them getting off the ventilator. So a failed spontaneous breathing trial really reflects persistent mechanical abnormalities of the respiratory system. So the respiratory system isn't quite healthy enough. So it's just not reversing quickly, so you're just going to have to take it slow, right? Just because it's going slow doesn't mean that it won't happen, right? So other causes or complications might be involved. They could have a compromised cardiovascular function. Let's say they had a myocardial ischemia from a heart attack. Maybe their fluid status has been impaired. Maybe they still have acid-base issues, or pain control is not appropriate, or they have inappropriate sedation levels, or maybe they need bronchodilator therapy. Maybe their nutritional status is appropriate. We're not giving them the right amount of substrates, right? Maybe there is some psychological factors as well that need to be addressed here too. So usually waiting 24 hours is that standard procedure to help us put together a plan for patients who fail their spontaneous breathing trial. So frequent spontaneous breathing trials over a single day have shown that they're not helpful and can actually lead to a lot of consequences. So even doing twice a day spontaneous breathing trials have shown no advantage over the once a day approach. So when it fails, we should get a stable, non-fatiguing, comfortable form of ventilatory support to that patient. So in other words, put him back on that mode where the patient doesn't do the work, right? That the patient gets the most support. So that would be your CMV type mode for at least 24 hours around that area to allow those muscles to unload, to optimize the patient comfort and sedation needs, prevent any complications. So that will help the patient sort of recover and see if that'll help them get ready. As long as the patient is not participating in the work of breathing and the workload is not fatiguing to the patient, they could breathe spontaneously as well. So it depends if you have them in like a proportional assist ventilation mode. But repeated spontaneous breathing trials the same day has been shown no benefit unless it was a sedation issue or something like that, right? So just repeating ritualistic attempts at the ventilator settings is not worth the time or the effort in the adult patient population currently. So there's no evidence that gradual support reduction is better than providing full support between once a day spontaneous breathing trials. If you're thinking SIMV all the way, man, right? No, there's no evidence that shows that's an advantage over just doing full support and then spontaneous breathing trials currently. Some things that you can adjust to improve comfort include the sensitivity level when you're weaning, right? You're triggering the patient triggering, adjusting the flow patterns when they're on the ventilator as well to make sure their work of breathing on assisted ventilation is minimal. Make sure you're preventing auto-PEEP if there is auto-PEEP. Make sure you facilitate the appropriate triggering there and possible reversing if you can. So the idea here is we're going to try to help your assessment of the potential for ventilator discontinuation, because that task force that I mentioned earlier with the American College of Chest Physicians, Society of Critical Care Medicine, the AARC, American Association for Respiratory Care, actually showed how poorly clinicians assess ventilator discontinuation, especially in patients that were considered ventilator dependent for longer than several days. So when we're looking at that, that really emphasizes the need for more focused assessment strategies for those hard to wean patients. Recommendation 7 states that the anesthesia and sedation strategies and the ventilator management should be aimed at early extubation and postoperative patients. So as soon as we can get them off and safely do so, right? A depressed respiratory drive and pain are the main reasons for their vent dependence. So a lower anesthetic sedation regimen may help them get an earlier extubation as well. So vent modes that guarantee a certain breathing rate, like CMV modes or even IMV or MMV that we just talked about a little bit ago, are important with unreliable respiratory drives. So the immediate postoperative patient may be ideally suitable for just that simple automatic feedback modes like that we talked about before from as a form of support. So MMV or volume support might be good for those patients. Recommendation number 8, when we're looking at the weaning protocols, and those are, the idea there is to optimize sedation. Now, can you imagine having something stuck in your throat and then having a very light level of sedation and not knowing what's going on? And when we're looking at protocols for ventilator discontinuation, they're usually designed for non-physician and clinicians, the respiratory therapist, the nursing staff, right? And usually they're implemented by us, the ICU staff. So they're aimed at optimizing sedation, and these are what you look at for therapist or nurse-driven protocols here. So therapist-driven protocols for weaning have been found to be safe and reduce hospital costs and shorten time required on the vent support. There are a variety of protocols that exist when we're looking at these, and your book gives some examples of these, but protocols heighten the staff awareness of the process and usually promote weaning success as well. So sometimes it's as simple as giving more power to the people, right? More power to the people that are taking care of that patient, that see them on a more regular basis than the physician group. A lot of times these protocols that are implemented by the respiratory therapists are recognized as being efficient, effective at getting them off, as well as the nursing and respiratory therapists to help make sure that everybody's informed that patient's progress is going in the direction that it should be going, or if they need more support, then we can look at that, and it might help them overall. So looking at weaning protocols should include therapist-driven and nurse-driven protocols that might actually help standardize and get this patient more support faster. Tracheostomy, recommendation number 9. Usually when it's apparent that the patient needs prolonged ventilator assistance. So after the patient's stable on the ventilator and the person looks like they'll benefit from the procedure, it should be performed as soon as possible after their need for extubation has been verified. So if they can breathe on their own and all that's preventing us from pulling the tube off is whether or not they can protect their airway, maybe we consider tracheostomy, and then once they recover from the tracheostomy, then we can take them off, right? So as soon as possible, as they're safe to do so. So usually within 7 days of onset of respiratory failure or sooner in neurosurgical patients, they might benefit this from having a trach earlier than later. Then they might have less days in the ICU, less days on the ventilator, less risks associated. So high levels of sedation are usually required for endotracheal tubes, but less are usually required for tracheostomy tubes. Patients with marginal mechanics that have tachypnea might actually do better with the tracheostomy tube. It has lower airway resistance than an endotracheal tube. Right? So that's a big advantage. Muscle workload is a lot less with the trach compared to endotracheal tube. They might get a more of a psychological benefit because they might now be able to eat, talk, or have greater mobility in physical therapy. They might be able to participate better now that they have a tracheostomy tube. But usually discontinuing ventilating support is a big advantage. So there is some lack of data that patients receiving long-term mechanical ventilation have less facial discomfort when they have compared to when they have an endotracheal or nasal tracheal tube. But it's been shown that there is a reduction in workup breathing and dead space ventilation. And then there's more effective secretion removal. Those are all benefits of the tracheostomy tube. So there is no data. There's clinically no data to indicate that the rate of ventilator-associated pneumonia is lower or shorter for those patients with tracheostomy. So that's also something to consider if you're looking at just ventilator-associated pneumonias as well. So things you have to look at there, the tracheostomy tube, the big concern there is that could take 7 to 10 days to really mature. And if it's inadvertently displaced, it comes out within 24 hours or something like that, then blind tube replacement is unlikely because that stoma can close up quickly and it can be very difficult. So it could be a very, very emergent situation. So make sure that when you do remove a tube, when it's stable, right? We're not talking about accidentally pulling it out, but down the road when we're just continuing a tracheostomy tube, the stoma is covered with some gauze pads held in place with some tape. It's just like an open wound, so it has complications of healing. It heals usually within a few days for most patients. So it can vary depending on the patient's baseline health as well, how long it takes for that to do that. Sometimes they might have to go to a trach button if the stoma needs to stay open for secretions or other reasons. And that's just a little hollow tube that's inserted into the stoma, and it has some flanges, and it can be capped during the day and then taken off at night. So that's another way of doing a progressive wean from a trach if a patient needs it. All right, recommendation 10, unless evidence of irreversible disease exists, a patient who requires prolonged ventilatory support should not be considered permanently ventilator dependent until 3 months have passed. So all weaning attempts during that time have failed. Those failing the wean may require placement of a long-term care facility. So that's where we think about giving them long-term facilities, and that's what we're looking at here. Usually 3 months, like I said, of failed weaning attempts for recommendation number 10. And so those facilities are really good at what they do. And so that's something that we might have to use if you're working in an acute care context, or maybe you're working at one of these long-term care facilities down the road. That's what they do really well. When we're looking at critical care practitioners, you should be familiar with these facilities. So you can help those facilities be identified and help them those that require long-term mechanical ventilation get the care they need as soon as possible. All right, as soon as their weaning attempts fail and they're transferred to that long-term care, as soon as they're stable, these facilities have demonstrated a lot of competence and safety in getting them off the ventilator. So they usually have fewer staff members, less costly monitoring equipment that make them less expensive than ICU, so they're using up less resources. So that's a big advantage. Usually they have to be medically stable and not being able to wean. The big thing here is to progressively reduce that ventilator support, reduce the invasiveness of the support, so more independence, preserve or improve their current function, and then maintain their stability. So it's a long-term game with their weaning procedures, and it works, right? They're designed according to a fixed, usually they're individually designed and not just a fixed protocol. So they're customized to that patient in that situation, and they can use a variety of techniques that really helps. Some patients may not need an artificial airway and just require non-invasive during the night, but when they do this, they usually wean slow-paced for these long-term patients. And so you'll see a difference if you're going to one of these long-term places. Usually the medical staff in these facilities includes a nurse, a respiratory therapist, and a lot of those patients are very experienced and understand the need for slow withdrawal support, and then just patience. Lots of patience, right? So patience is a virtue, just lots of patience in those places. So patients with chronic conditions like ALS, or muscular dystrophy, chronic lung disease, loss of the drive to breathe, phrenic nerve damage, paralysis, cervical fractures, other types of neuromuscular conditions, they might require permanent mechanical ventilation. So in those cases, long-term ventilation refers to the means of support of patients who are not acutely ill, but who are presumed to have a permanent case of needing mechanical ventilation support. So ventilator dependence can be challenging for patients, but it does not have to be confining. And many patients that have ventilator dependence have very, very meaningful lives outside the hospital. I've seen videos of patients that are at Craig Hospital where they have programs where they're skiing down a mountain, right? And their ventilator's alarming because they're just having fun. I've seen videos of them on hunts, like hunting and doing all sorts of things. So don't think that these people can't have a high quality of life just because they're vent dependent. All right, and finally, the ethics. The ethical and economic issues related to life support are more important every day. We are seeing cost of medical care just increasing and increasing, and the availability of payment just declining, and the ability and population just aging. So we're having a lot of issues, and there's a lot of ethics out there. And I'm not advocating for any one position over the other. I'm just stating some current issues that are out there. So please take that into mind, right? I'm not trying to advocate for one position or another. Withholding and withdrawal of life support are important ethical issues related to death and dying. So just be sure that is part of what we do, is we're in the area of death and dying, and there's a whole ethical consideration here, and way more complex than what I have time to on here, and probably than what you want me to go to on here. The ethics of discontinuing life support. Very complex, very wide, and I think that's a conversation best held for another day.